physicians have said it's a good time to have IBD, so it's got to be true, right? Last but not least, we have one more person who's going to speak with us tonight, and she's going to talk about the importance of building a good relationship with your nurse, so good patient-nurse relationships. Usha Chauhan is a specialist nurse practitioner for adult GI care at the Hamilton Health Sciences McMaster IBD building. So please give a warm welcome to Usha. To speak today, I'm going to be talking about building nurse-patient relationship in IBD. So what I'm going to be doing is review the Canadian nursing education and the nursing roles within Canada, examine IBD nursing models. Here, we don't have any here, but internationally, examine nursing roles within IBD care, and discuss the adult IBD nursing team at McMaster. So Canadian nurses are categorized based on the education. So we have registered nurses, we have registered practical nurses, then registered nurses, and then we have advanced practice nurses. And within advanced practice nurses, you have clinical nurse specialists and nurse practitioners. Now, I'm just going to review the education that each category of nurses have. And nurses, once they go through the education, also have to sit a licensing board exam. So a licensed practical nurse has a 2 to 3 year diploma from college and can practice autonomously once they have received the diploma and passed the exam. Whereas a registered nurse is a 4-year baccalaureate nursing degree at a university level, and again, they sit an exam. And since 1990, registered nurses are degree nurses. Prior to that, they were college trained. You then have clinical nurse specialists, which are registered nurses, worked as a registered nurse for at least 2 years, but then go back and get a master's degree. They are advanced nurses. They have clinical expertise in theory based on research, interests that they have, and they focus on specialty nursing areas. You have nurse practitioners. Nurse practitioners, again, have 2 years of registered nursing training, first of all, and then work as a registered nurse for 2 years before they go back to school and get a master's training. In addition to that, they also need to have 750 hours of clinical practice at an advanced level so that they can work at an advanced level, interpret diagnostic tests, communicate diagnosis, are able to prescribe. And in Ontario, we write an exam, and I think we write exams right across Canada. Once you write an exam, you have a designation called Extended Class or EC after your RN designation. Then we have a doctorate of nursing. So these are PhD nurses. These are advanced practice nurses that have a PhD degree, have a specialty area that they work in, and have a basic nursing interest. Oftentimes, you find them at an academic center with as a tutor or a professor in nursing, and they also have clinical roles as well. So when you look at practice and you look at patients, registered nurses are working with more complex patients that are in the ICU, and registered practical nurses are working with patients that are a little bit more stable, sometimes in community centers or in a home. But in the hospital, with the cutbacks, they have cut back a lot of the registered nurses and are replacing them with registered practical nurses. I'm not saying there's anything wrong with that, but what I'm saying is that the practical nurses have a diploma degree and limited practice. Some of the registered practical nurses are excellent. We have a nurse working in our area in hepatology, and she has done some advanced courses, and she is an excellent practicing nurse. So a nurse practitioner's role was derived from blending clinical, diagnostic, and therapeutic knowledge, skills, and ability to within the nursing framework. And it emphasizes on holism, health promotion, disease prevention, and partnership with individuals and families and communities. The education experience of nurse practitioner allows them to function both independently and within a team where they work collaboratively with physicians. You see a lot of nurse practitioners in primary care working with primary care physicians in the community. So to build a therapeutic client relationship, nurse that establishes some of the key things that they work on using the knowledge, skills, and have a caring type of attitude to talk to patients. Like Dr. Eisenman said, building that relationship is very important. You have to talk to patients at their level. So I talk to young adults a little bit differently than patients that are a little bit older. So the therapeutic nursing service adds to the client's health and well-being. The relationship is based on trust, respect, empathy, and professional intimacy. So when you look at IBD care, like we have Dr. Eisenman has just spoken, it has to be an interdisciplinary care. Because IBD is so complex for some patients, you need to make sure that all aspects of care are provided. So when you have ongoing GI issues, you need to make sure that you have a gastroenterologist who's going to take care of the medical side of things. We know that IBD is very unpredictable, it's lifelong, it has complicated treatment decisions. A specialist nurse often fills that role and is a point of contact when the patients are running into problems, or if the patients have got questions about treatment, and if they're unsure of what they need to try. It affects the GI tract, so of course you're going to need a dietitian. Dr. Marshall did say there is no diet that helps the IBD, but if you look at diet, you manipulate the diet to help the symptoms. We know that IBD is lifelong, and it can affect quality of life, and it can affect relationships. Oftentimes, it's difficult to manage and cope with the day-to-day symptoms. Psychiatrist or psychologist is a person to see. We are fortunate we have a psychiatrist, and we also have a psychologist that's going to be starting in the adult clinic soon. As we said, IBD treatment can be very expensive and can cause financial burden, especially if someone's not working. And we have patients that have difficulty making ends meet. So we don't have a social worker within our setting, but oftentimes the family doctors do have a social worker working with them that they can help to find out where they can get some financial help from. Can lead to possible, so IBD can have complications associated with it, with abscess, scarring, fistula, or as we said, malignancy is not very common, it's very, very rare, so you need to make sure you have a colorectal surgeon as part of your team. Again, like Dr. Eisenman says, health maintenance is a key thing, and in the adult world, always refer patients to the primary care physicians to make sure that all the annual checkups and vaccinations and everything is up to date. So, nursing roles in IBD. IBD nurses play a very important role in managing disease, talking to patients. I spend a lot of my time counseling patients, providing ongoing support. I have patients that take a long time to make decisions about therapy, and I am spending, minutes, hours with patients talking about the disease and the treatment options. And I believe that patients, even if they've had the diagnosis of IBD, say for 5, 10 years, they always learn something new when I go and talk and review the disease with them, as well as the treatment. with the evolving role of advanced practice nurses who can investigate, who can diagnose, prescribe therapy, monitor therapy, and is within the scope of practice. So oftentimes patients do call me if they've got a problem, and I will order the test, I'll fax off a requisition for them, and make sure that some of the tests are done before they have an appointment. Nurses spend more time with the patients, and that will provide them, provide a holistic approach to care. I find that patients often tell me things that they will not want to talk to the doctors about. And as I said, they tend to confide more readily to nurse than the physician. I often spend like 10, 15 minutes with patients, and I say, well, shall I say any of this to the physicians? No, it's fine, you've answered all my questions. Then they're pretty happy with what answers they've gotten. So how is the role of IBD nurse established? This has been going on for quite some time, the last 15 years. So this is one of the first papers that was looking at effectiveness of specialist nurse in management of IBD. And since then, there have been a number of other research studies that have been done to look at the role of IBD nurses within IBD teams. And most of them show that IBD nurses spend time, patients confide in them, provide more quality care, answer the questions, and patients, in one of the studies, patients were happy to talk to nurse rather than the physician as well with some of the symptoms that they were having. And as you can see, this research is being done in Europe, Australia, United Kingdom. Europe and United Kingdom are the leaders when it comes to looking at nursing roles within IBD care. So what is the role of IBD care? So I have developed this model looking at what does nurses do within IBD care. I look at it as a gatekeeper, clinical assessment, providing prompt access, so I talk to patients on the phone, work within a collaborative care team, so provide collaborative care within a team, ongoing education, empowerment to patients, especially some of the patients that are unsure about the treatment options that they have, and conduct quality research. So as a gatekeeper, you're a point of contact via telephone or email during the time when the disease is flaring, answering questions about medication side effects or questions about medications in general. I get about 8 to 10 phone calls per day, and about 8 to 10 emails per day from patients. As a gatekeeper, you screen and determine the need for a prompt access appointment, order lab tests and investigations before an appointment, like I've already mentioned, determine the cause of exacerbation. Sometimes what's happened is that the patient hasn't taken the medication. So you say, okay, so the last time you were seen, you were on this medication. Tell me about the medication. How often are you taking it? Are you still taking it? And you find out that they're not taking it. So then that way you can just treat the patient. Say, start taking it or increase the dose if you decreased it, and that'll help as well. Again, making therapeutic decisions based on the symptoms and make recommendations. Clinical assessment and prompt access. Since my role was developed about 5 years ago, we have a prompt access clinic, which is a half-day clinic on a Thursday morning. And when patients call me, say on a Monday or a Tuesday, I can easily put those patients on a Thursday. Or if I can't, then I have my own clinic, and I would see them in my own clinic so that I can see the patients pretty promptly. And as far as assessment prompt access, if we see patients promptly, it reduces emergency room visits, decreases burden of illness, reduces anxiety associated with the disease, prevents complication, reduce healthcare costs, improve quality of life. And these are all demonstrated in the studies that have been done. Working within collaborative roles, I often, when I'm making decisions, I collaborate with the physicians And I talk to them and I say, this is the recommendations I made. What are your thoughts? Are they okay? Patients are very willing to wait for that second phone call if I'm unsure, because I've talked to the physician. So when you're working within collaborative team, you have a gastroenterologist, a dietitian, a social worker, as I've mentioned, a surgeon, a psychiatrist. Oftentimes, even if I'm concerned about a patient and I want the psychiatrist to see the patient, I would talk to the psychiatrist personally, and I'll say, you know, I'm really concerned about this lady. Please, person, can you please see this person? Facilitate transfer, pediatric transition, just like Dr. Eisenman said. So we did do a study where I did go down to the pediatric clinic on the second last visit, and I think the patients really appreciated seeing me there, because they had, like Dr. Eisenman said, had a face and a name and a contact point for a person when they transition to the adult clinic. I also facilitate referrals to all of the other disciplines as well. I don't do inpatient care, but there are nurses across Canada, or nurse practitioners across Canada, that do both inpatient care as well as outpatient care. So they would see the patients when they're in the hospital and then follow them in the outpatient clinics as well. And these are nurse practitioners. So in the education role, I provide ongoing teaching about disease information, like I have already said, medication options, and I spend a lot of time with medication options. I have patients that, you know, are given information about the anti-TNF therapy, are thinking about it, not sure, they don't want it, and really want to find out why do they not want this treatment. So once you find out why they don't want the treatment, then you educate them, and you often find that they'll say, okay, well, I'll try this, and then we'll talk a little bit more with you with regards to the treatment goals. So again, education with regards to medication adherence, like Dr. Eisenman says, you know, we have patients that don't take medication, and you see them, and they're not doing very well. But the way I approach it is that it's fine not to take medication. It's your choice not to take the medication, but there are consequences that you know, that can occur when you're not taking the medication. And oftentimes, you know, giving them tips, like if the patients are on once-a-day medication, forgetting to take it because that's not what they want to do. So I give them tips. Well, you know, what do you do on a regular basis that's going to allow you to take the medication? Brush your teeth, keep your medication right by your toothbrush so you can take the medication. Importance of laboratory investigations. We have patients that are on immunomodulator therapy, need to have regular blood work done. And oftentimes when they come for a follow-up, they haven't had blood work done for 3 or 6 months or more. You again, educate them, say, do you know why we're doing this? And once they know why we're doing it, they do comply a lot of the time. IBD, as you know, is classified as an invisible disease. What that means that you're suffering in silence. You've got cramping, you've got diarrhea, you're not going to talk about it to anybody. And what you need to do is to help them support and discuss the coping strategies with the chronic illness that they're living with, especially when you have concerns such as, you know, diarrhea or even fecal incontinence that some patients do have. And it's very, very difficult to be living with that. Again, like Dr. Eisenman had mentioned, health maintenance and vaccination, physical exam, importance of healthy eating and physical activity, and promote self-management. So really, you want the patient to take charge of the disease themselves. How to do that? They can always call me and talk to me about, you know, if they want to make any medication changes. But if they know they can do it, they'll go ahead and manage. They're controlling the disease themselves. They own the disease, and they need to control it themselves because they're going to live with it, especially some of the young adults that have the diagnosis at, you know, in the teen years, and you have to live with that disease for the rest of their life. Empowerment. So it's a key point. I play a key point in contact with the patient, so they help them talk again, you know, discuss issues with them, act as an advocate, focusing on managing the symptoms in the context of their life rather than, in the context of disease management. So what are they dealing with? What kind of issues are they having? Some patients they don't have any money. Sometimes I hear stories, Usha, I have no money. I cannot afford to buy the food. So, you don't know that unless you start talking to patients and trying to live with symptoms within their life. And then you try and help them out. Listening attentively, allowing for honest dialogue about IBD as a chronic illness and the impact that it has on your life. Again, attentive listening. I had a patient not so long ago. She had 2 or 3 appointments with me back to back. And I said, I'm sorry you haven't gotten an appointment with a gastroenterologist. Should I make one? No. She said, I'd rather come and see you because I know you listen to what I have to say and you will act on what I say to you. And she had no problem saying this. So the primary focus of a nurse is determining patient's ability to manage the disease within the context of their life, listening to their concerns, providing care and information according to the individual needs, assess and advise based on, when they're not feeling very well. With regards to research goes, nurses are doing research to see how much impact they have on their role, on the patient care. In the UK, the nurses in the UK and Europe do a lot more research than Canadian nurses do, but having said that, IBD nursing in Canada is growing, and we are just starting. So we're just really following the UK and European model. So in Yorkshire, they did an audit, telephone audit, and across Yorkshire to look at how nurses work on the telephones and provide phone care, and found that providing the phone care saved money for follow-up visits, and that then saved money so that they could provide for their own. Self-management is another studies that were done in Luton. Teaching how to inject. This study was done in the US. So when young patients are starting to self-inject, injection can be really painful. It can be very disturbing. So the nurses figured out how to do this by having the patient lie in a bathtub, and while they were in the bath, the body was warm, and teaching them to do the injection. It was not as distracting and disturbing for the patient to do the injections. Again, IBD within a school, as a nurse, working in a school, knowing about IBD, the nurses will be able to manage the children when they're at school if they're having any problems. So this was another publication that was done. Again, here, Dr. Eisenman has already mentioned this. So this is done by Karen Frost at Sick Kids. They developed this My IBD app, which is really used internationally right now. And it's a very useful and friendly, children-friendly or young adolescent-friendly app that is being used. They've also got My IBD Passport as well at Sick Kids. Barbara Curry in Halifax did a study looking at patient quality with quality of life and patient satisfaction when they see nurse practitioners, and they felt that the patients were happy and to discuss any intimate or any personal issues with nurse practitioners, and were very, very satisfied with the care that they provided. So in Halifax, you've got Barbara Curry and Kelly Phelan Kelly are the 2 first nurse practitioners in Canada that started to work as nurse practitioners in Halifax. Here we looked at prompt access clinic when my role was first developed, and we found that patients were happy to be seen by any gastroenterologist when I gave them the prompt access appointment. It did not matter if their primary GI was doing that clinic or not. As long as they were seen, they were happy to be seen within a short period of time. More research that has been done, so IBD support groups, and this was done in the U.S. We have at Mount Sinai, Brenda O'Connor has also got an IBD support group with patients having ostomy, as well as a support program there. Unfortunately, here at McMaster, we don't have one, but hopefully in the near future, we can look at something like that. Currently at McMaster, I'm conducting a pilot study looking at patient satisfaction and patient preference with clinic follow-up versus telephone follow-up. So we're just in the middle of conducting that study, so stay tuned for the results of that study, hopefully next year. So when I looked at the model of IBD care, that's the model that I envision myself and looking at care that I provide. But in the UK, Marion O'Connor and the team could put this together, this model, and it basically looks at all the aspects that I have talked about, but individually. So you're looking at nurses working in, with patients that are on immunomodulators, counseling and monitoring. So nurses are very closely monitoring to make sure that patients are getting the monthly blood work done and are tracking the blood results. I had an opportunity to spend 2 days at St. Mark's Hospital, and 3 nurses sitting there on the phone talking to patients all day, the 2 days that I was there. They also spend time in the clinic too, and they do infusions in their own area there too. Again, education, as I've already alluded to, providing anti-TNF therapy. So in Canada, what we have is the BioAdvance and Progress Nurse programs that employ nurses that talk, look at coordination of therapies for patients. So in Canada, it's a little bit different, but in the UK, the nurses are playing that role. Rapid access, as we talked about, telephone advice, as we talked about, follow-up visits. Nurses would do that in the clinic, counseling, working within a multidisciplinary team, inpatient reviews, as I've said, liaison with GPs. So the nurses, when they see and talk to the patients in the UK, often send a letter to the family doctor to let them know what they've done, and a copy is also placed in the patient's charts too. Staff educator, research, and policy and protocol development. So at McMaster, we have, I'll just review in the adult clinic, we have 2 research nurses, Gail Capelli and Mitzi. I think they're in the audience somewhere hiding. I wanted the pictures, but they are refused. And we have the TPN nurse, Carol Gordon. So if the patient has had a number of surgeries, bowel resections, and have a short gut, they often need parenteral nutrition, which is provided in the community. But Carol Gordon, along with a dietitian and Dr. Armstrong, run this program. And we do have a few IBD patients that are in that program as well, and that's a registered nurse who's running that program. The ostomy nurse, Nancy Chapazzo, she's working here at this site, but we have other 4 or 5 ostomy nurses working at the General and the Jervinsky site as well. Really very resourceful. I've learned a lot from working with Nancy when patients are having ostomy issues or even skin issues or with perianal fistulas that some patients have. Myself, so Suzanne Henson is the dietitian. She sees patients with IBD and has a clinic just for IBD patients, and she also is a dietitian and sees the other GI patients as well. In addition, we have a clinical research associate, Melanie Wolf, who was the one person doing the fecal microbiota study, coordinating that with Dr. Paul Moyetti. And she is a lab technician, but she is a certified clinical research associate. So in summary, I have looked at the Canadian nursing roles in education, summarized specialist IBD nursing role within a multidisciplinary team, summary of research. Some of the research that's done, there's a lot of research that's done looking at the impact of that the nurses play in IBD care, and reviewed a couple of models, the one that I was looking at, as well as an international model. Provide IBD care within a multidisciplinary team, and looked at a couple of allied healthcare providers that are working within our team. In addition, we've also got a number of research assistants that are also working with IBD patients as well, doing clinical trials. Zach being one of them, he is here, and a number of other research assistants. So thank you very much for allowing me to present. And I guess we'll have questions as a panel, right?